Lucky Land Casino, asking people, what's the weirdest place you've gotten lucky?
Lucky? In line at the deli, I guess?
Aha, in my dentist's office. More than once, actually.
Do I have to say?
Yes, you do.
In the car before my kids' PTA meeting.
Really?
Yes.
Excuse me, what's the weirdest place you've gotten lucky?
I never win and tell.
Well, there you have it. You can get lucky anywhere, playing at LuckyLandSlots.com. Play for free right now. Are you feeling lucky? No purchase necessary. Void where prohibited by law. 18 plus. Terms and conditions apply. See website for details.
Hey all, welcome back to another episode of the Real Life Pharmacology podcast. Today I'm looking at the drug Metolazone, which has a brand name of Zaroxolyn. Now, I have covered thiazide diuretics and thiazide-like diuretics in a general sense. There are a lot of clinical quirks and pearls with metolazone specifically that I really wanted to cover this drug specifically in a little more detail. So that classification, it is considered a thiazide-like, thiazide-similar diuretic. The primary indications where I see this used in clinical practice is, number one, at least in my geriatric patient population, is in augmentation of fluid loss in patients experiencing symptoms in CHF. Okay, so that's augmentation in combination with a loop diuretic, typically furosemide, as kind of an add-on therapy where maybe we've escalated doses and the patient didn't tolerate higher doses of a furosemide, or we've gone up on doses and we, don't want to go any higher, so we want to add another diuretic that maybe works by a different mechanism of action. Now, metolazone can be used for hypertension. I have seen it a few times, maybe more so in combination with CHF and fluid relief or relief of edema. So there are a couple other rare indications that you may see it for, but I would say by and large I see it mostly used for fluid loss in CHF. Mechanistically, how this drug works is it blocks sodium reabsorption in distal tubules. Now, with that sodium loss, water, potassium, potentially magnesium, hydrogen ions potentially all go with that out of the body and obviously out through the urine. So you can obviously postulate from that mechanism of action what you're going to see in adverse drug reactions, and electrolyte abnormalities are definitely a big concern. In clinical practice, I've definitely seen profound potassium wasting when this medication is added on to a loop diuretic. So say you've got a patient that's maybe got a potassium of 3.4 to 3.8, and we've still got an excess of fluid, and we're looking to add another diuretic like Zaroxolyn, you can definitely anticipate upon initiating that drug that we might get to low levels of potassium, and dangerously low levels of potassium if they're kind of right in that lower borderline of normal there. So with that said, you've got to watch electrolytes closely when initiating and when changing this medication for sure. A couple other things with the loss of those electrolytes, so hypomagnesia can happen, hyponatremia. I think of this as an additive effect. If a patient's taking other medications that can cause that sodium loss, maybe through like SIADH, for example, your SSRIs, your Tegratols, things of that nature, definitely something to really look out for and get that baseline level before you start the medication and say, are they at risk for even lower levels or significantly low levels if we add on this drug? So definitely keeping tabs on that. Rarely there can be an alkalosis associated with this medication, and again, that kind of plays into the mechanism of sending hydrogen ions, which excessive hydrogen can cause a state of acidosis. So if we send out a lot of hydrogen ions, we can potentially get the opposite effect of alkalosis. Dosing of Zaroxolyn, the most common dose I see, but again, I work in geriatrics, so folks tend to be a little bit more cautious there. 2.5 milligrams, and I've seen it as low as, one time a week. The drug does have a little bit longer duration of action, which, maybe allows you to spread out that dosing, but 2.5 once a day, even down to 2.5, once a week or a couple times a week, I have seen this medication dosed at. So, again, kind of depends upon, the risk of fluid retention and what that's causing for the patient, compared to how much, fluid you want to pull off, and the risk of over-aggression and the risk of dehydration, acute renal failure, and things of that nature. Electrolyte imbalances as well, of course. So I did want to cover, that risk for dehydration. You pull fluid off, that's going to increase your risk of acute renal failure. That's something we always have to monitor pretty much with any diuretic. Uric acid is one more thing we should keep tabs on, particularly in our patients with gout. Thiazide-like diuretics can increase uric acid levels, so definitely keep tabs on that. Now, metolazone is a little unique in the thiazide-like diuretics, in that we may have a little bit more evidence that it works better in patients with poor renal function. Now, this is a little bit controversial. I've spoke with cardiologists about this. I've asked them that question, and if you're using metolazone for something like hypertension and hydrochlorothiazide for something like hypertension, in theory, from maybe some of the evidence we have, metolazone could work a little bit better as that renal function is lower. But there again, we can monitor patients clinically. Is this drug helping their blood pressure? Did their blood pressure drop when we started this medication? So whenever we have controversial situations and questions whether medications work or they don't work, those are good times to take a look at the patient individually and say, hey, is this medication actually working following starting or increasing a dose, or whatever we're changing there. So keep tabs on those patients in situations where we're not sure about the clinical efficacy of a specific medication. So things we're going to monitor: the electrolytes I mentioned, renal function I mentioned, fluid status. Obviously, we're going to look at that if we're managing edema, for example. In patients with CHF, we're obviously going to try to look at weights as well in part of that fluid status assessments. And if patients are losing too quickly, that's obviously maybe indicative, okay, we're running off too much fluid. And if they're gaining weight, well, maybe the dose isn't high enough. Maybe we need to be more aggressive. Again, looking at the fluid status as well as the whole clinical picture of that patient. So let's take a quick break from our sponsor here, and I will finish up with drug interactions. If you're in the market for pharmacist board certification study material, such as pharmacotherapy, ambulatory care, medication therapy management, geriatrics, or the NAPLEX exam for students, definitely go check out meded101.com/store. We've got great lists of resources there, multiple programs with several hours of videos, quiz banks, handouts, all sorts of different stuff as comprehensive packages to help you prepare for your board exam. If you're looking for a book on clinical pearls, case studies, and just gaining a better comfort with medications, medication management, I've had a lot of nurse practitioners, PAs reach out. Definitely go check out our Amazon books, such as Thrill the Case, Pharmacotherapy, my latest drug interactions book. Definitely going to give you a lot more confidence in managing medications. So go check out those resources. If you've never had an Audible book, you can also get your first book for free on Audible. So go take advantage of that. Some of the books I have are 8 to 10 hours in length there. So great opportunity to get some essentially free education, and check out audible.com as well. All right, so let's finish up on drug interactions. So the first thing I think about is other diuretics, because I have seen metolazone added on top of, like I said, loop diuretics so many times. So we've got that potential for additive effects on electrolytes and also that risk for dehydration and monitoring that kidney function. So very, very important to keep tabs on that. Other medications that can be nephrotoxic, I keep those in mind as well. So, NSAIDs, ACE inhibitors, ARBs, those are all examples of medications that can potentially induce acute renal failure. And it can have that additive effect if you're using diuretics with those medications. Binding interactions with a drug like cholestyramine, that can happen. Not incredibly common, but obviously we'd look for reduced effects, reduced benefit, lower drug concentrations with an interaction like that. Calcium supplementation. So this is one I didn't mention. I don't believe I did in the electrolyte alterations. Mechanistically, uniquely compared to loop diuretics, metolazone works a little bit differently. And in its mechanism, it actually allows for the reabsorption of calcium. So you may see higher calcium levels in patients on metolazone. So what that means is, keep tabs on calcium supplementation, vitamin D supplementation, and obviously those calcium levels. If you see those calcium levels rising, if you've got a patient that's maybe taking super therapeutic doses of calcium for some reason, some odd supplements, that could be a situation where we could have some additive effects there. So definitely, again, what we're going to do to handle that situation is just monitor calcium levels as well as all the other electrolytes, of course, there. And then the last interaction that I wanted to cover was thinking about those gout medications and how metolazone could potentially go against what we're trying to do with a drug like allopurinol. So allopurinol, we're trying to bring down that uric acid. Metolazone could oppose that effect and potentially raise those uric acid levels. So I think that's going to wrap it up for today. If you want to follow the podcast and also get a free 31-page PDF, go to reallifepharmacology.com. Sign up. You'll get sent an email with the top 200 drugs and the most important, at least from my perspective, clinical pearls that you're going to see with those top 200 drugs. So great resource if you're a nursing student, pharmacy student, med student, young healthcare professional, just to get a sense of some of the most important things with the top 200 drugs and things you should look out for. If you enjoyed the podcast today, definitely go leave us a rating, review on iTunes or wherever you're listening. It's greatly appreciated. Share us on Facebook, Twitter, Instagram, whatever social media platform you use. Definitely share this podcast with your healthcare and medication-loving friends. Shoot out an email to your class, professors, whoever, if you find this information valuable, helpful in your preparation in becoming a better healthcare professional. You can track me down at reallifepharmacology.com, hit the contact button. Maybe a better way is LinkedIn. I'm fairly active on that social media platform, so you can connect with me there. And, of course, meded101.com. You can connect as well when you're checking out the resources there at meded101.com/store. I'm going to sign off for today. Thank you guys so much for listening. I hope you guys have a great rest of your day, and we'll catch you on the next episode.
With the Lucky Land Slots, you can get lucky just about anywhere.
This is your captain speaking. We've got clear runway and the weather's fine, but we're just going to circle up here a while and get lucky. No, nothing like that. It's just these cash prizes add up quick. So I suggest you sit back, keep your tray table upright, and start getting lucky.
Play for free at LuckyLandSlots.com. Are you feeling lucky? No purchase necessary. Void where prohibited by law. 18 plus terms and conditions apply. See website for details.